Good evening, everyone. It gives me great pleasure to announce the first webinar of CCI for the year 2025. And of course, Dr. N.S. Krishna, Dr. Vijay Kumar, and the team has brought this very interesting topic of hiccups, daytime and sometimes nightmare. So we're basically going to discuss chronic hiccups. And it's a very interesting topic because we don't often talk about it. And we do see patients in our clinic and in our admitted patients. So for this very interesting webinar, we have a very truly an MDD discussion that is going to happen because we have with us Dr. Abhinav Gupta, who is a gastroenterologist from Jaipur. We have Dr. Gagan Gunjan, who's a internal medicine specialist from Ranchi. Dr. Pravin Taware, who's attached to Gleneagles Hospital, who's a pulmonologist, very young, budding, upcoming pulmonologist from Mumbai. And we have Dr. Ashutosh Gupta from Prayagraj Respiratory Care Center. So with that, I would like to we will have two presentations followed by a question and answer session. If you all have any questions at any point in time, please post it in the chat box and it will be answered in due course.
Thank you, Pratibha ma'am, for such a nice introduction. I am Dr. Abhinav Gupta. I'm a consultant gastroenterologist and hepatologist at Narayana Hospital, Jaipur. Today we are here to discuss on pathophysiologically, basically on hiccups. So hiccups derives a sound from, erroneously implies an association with respiratory reflexes. The medical term singultus is thought to have originated from Latin singult, which translates roughly as the act of catching one's breath while sobbing. Hiccups are also called as synchronous diaphragmatic flutter. So, hiccup is the state of having a reflex spasm of the diaphragm accompanied by a rapid closure of the glottis, producing an audible sound, sometimes a symptom of indigestion or breathing spasmodically. It's been classified into an acute, persistent, and intractable. Acute, which is less than 48 hours, persistent, which is more than 48 hours, and intractable, which is more than 1 month. If we go on to epidemiologically versus, so there are 55 cases per 1 lakh patients, in which both CNS and GI tract both are involved. Mostly in CNS tract diseases it's been found, but many GI tract diseases are also been involved. If we go on with 20% of Parkinson's disease, 10% of reflux diseases, 3.5 to 4.5, 3 to 5% of patients with advanced cancers have persistent or intractable or recurrent hiccups. Now, the main topic of today is pathophysiology, in which how it is involved. It's been basically an hiccups reflex arc, in which involves an afferent limb and intensive interconnection within the brain and then the efferent limb. And the afferent limb, it consists of phrenic and vagus and any thoracic sympathetic chain. Then there is an intensive interconnection among the hypothalamus, medullary reticular formation, respiratory centers, cranial nerve nuclei. Then there is an efferent, which involves the phrenic nerve again, recurrent laryngeal branch of the vagus nerve, and the motor nerves to the anterior scalene and intercostal muscles, in which there is a spasm of the diaphragm leading and also the closure of glottis, leading to a sound of hiccups. So basically, hiccup center is in the upper spinal cord of C3 to C5 in the medulla oblongata near the respiratory centers. Along with there is the vagus nerves. Now we can see there is both afferent limbs also and efferent limbs also. So there is an anatomy of hiccup reflexi are any pathology affecting the brain, diaphragm, thoracic or abdominal viscera can stimulate vagal or phrenic afferent and activate the diffuse hiccup center in the midbrain, brainstem, and proximal cervical cord. This triggers a repetitive myoclonic contraction of the diaphragm and other respiratory muscles via the phrenic and the intercostal nerves. Immediately afterwards, leading to an activation of recurrent laryngeal nerves, closes the glottis, producing a characteristic hic in the hiccup. So basically, overall, the motive is that there is an input via the serotonergic neurotransmitters, which activates the brainstem, the hiccup center in which involves nucleus tractus solitarius, dorsal vagal nucleus, and nucleus ambiguous. Along with this, there is a neurotransmitters involved, leading to an activation of the diaphragmatic muscles and intercostal muscles, and then leading to a formation of hiccups. There are many transmitters are also involved, like dopamine, serotonin reuptake inhibitors, norepinephrine reuptake inhibitors, that might increase or decrease the development of hiccups, and they might be having a role in the treatment of hiccups. There are many causes in which includes cancer, multiple tumor types that may involve abdominal, thoracic, or central nervous system, metabolic derangements, including electrolyte disorders, uncontrolled diabetes, uremia, hypoadrenalism, central nervous system disorders like meningitis, encephalitis, stroke, and hemorrhage. But most common of stroke is lateral medullary stroke, in which there is more common chances of having persistent or intractable hiccups. Pulmonary and cardiothoracic diseases are there. Gastric disease is also there. Surgical, like while giving anesthesia, drug-induced epidural injection drugs, thoracic procedures might having leading to development of hiccups. Medications are there in which may have to increase the neurotransmitters release and leading to development of hiccups. Now I transfer this session to Dr. Gagan Gunjan for the management of hiccups. Thank you, everyone.
Very, very good evening to all of you. At the outset, I am very thankful to Chess Council of India for providing me with this platform to reach out to all of you on such an important topic, that is chronic hiccups. You have already seen my previous speaker, Dr. Abhinav Gupta, how he has very well dealt with the anatomy, physiological, and molecular part of this topic. I shall take you further through the remedies and management of this topic, that is chronic hiccups. So let us start. To introduce you with the topic, hiccup is an involuntary contraction of the diaphragm that may repeat several times per minute. The hiccup is an involuntary action involving a reflex arc. Once triggered, the reflex causes a strong contraction of the diaphragm, followed about 0.25 seconds later by closure of the vocal cords, which results in the classical hic sound. Hiccups may occur individually or they may occur in bursts. The rhythm of the hiccup or the time between hiccup tends to be relatively constant. Generations of physicians have failed to discover a definitive cure for hiccups. The following statement from the Mayo Clinic, though made in 1932, still describes the situation perfectly. Patients rarely present to the ED after cessation of a brief episode of hiccups. If this occurs, the possibility of another reason for the presentation should always be considered first, and then we should only think of any particular drug or pharmacotherapy. Therapy is usually directed first at the cause of the hiccups and then toward the hiccup themselves. If you look back at the history, then the most chronic hiccup in history is that of Charles Osborne, who had non-stopping hiccups for almost 68 years, from 1922 to June 1990. According to the Guinness Book of World Records, this is the longest bout of the hiccups ever recorded. If we classify hiccups, then we can do it in the three forms, that is acute, persistent, and intractable. Acute is anything less than 48 hours, persistent is something more than 48 hours, and intractable if it persists for more than 1 month. The most common triggers for hiccups that last less than 48 hours are usually drinking carbonated beverages, excitement or emotional stress, drinking too much alcohol, eating too much, sudden change in temperature, or swallowing air with chewing gum or sucking on candy. Causes of hiccups that usually last more than 48 hours can be grouped in the following ways: nerve damage or irritation, CNS disorders, and metabolic disorders or drugs. If we look at the factors that may cause damage or irritation to these nerves, this may include either a hair or something in the ear touching the eardrum. It could be a tumor, cyst, or goiter in your neck, or it could be sore throat or laryngitis, and most common and benign form, that is GERD, can be the cause. Damage or irritation is usually of the vagus nerves or phrenic nerves, which supply the diaphragm muscle. If we look at some of the central nervous system disorders, a tumor or infection in the CNS or damage to the central nervous system usually result in trauma that can disrupt your body's normal control of the hiccup reflex. This precipitating cause could be either meningitis, encephalitis, tumors, multiple sclerosis, stroke, or traumatic brain injury. Other causes can be anesthesia, barbiturates, alcoholism, metabolic drugs, certain metabolic underlying conditions like diabetes, or certain drugs like tranquilizers or electrolyte abnormalities. Sometimes mental or emotional issues like anxiety, stress, excitement, or some form of surgery after undergoing general anesthesia can provoke hiccups. If you look gender-wise, then men are much more likely to develop long-term hiccups as compared to women. This, in a nutshell, describes the frequent causes of persistent intractable hiccups. You can see all the CNS and PNS, peripheral nervous system, or other causes like toxic metabolic, pharmacological, surgical, or psychosomatic disorders. These all can result in chronic or intractable hiccups. Now the question arises, do we need to address? The answer is yes. If hiccups start interfering with your sleeping pattern, speech abnormalities, eating habits, and post-operative wound healing, then we definitely need to address this issue. If we look at this algorithm, then persistent or intractable hiccups, then we need to have a definite approach regarding its management. We need to have a thorough history and physical examination. If we can find an obvious cause, then we should go for electrolyte panel, chest radiography, or ECG. If suspected causes are there, then we need to further work up. And if cause could be found out, then we need to treat specific reversible causes. If the causes are could not be found, then it can be classified as hiccups in the category of refractory hiccups. And then we need to have certain non-pharmacological treatment options. First, go for non-pharmacological treatment options, and then only we should think of pharmacological treatment. Then we need to have certain lab tests like blood tests for diabetes, infection, kidney disease. If we plan for further investigations, then we can go for X-ray, CT, MRI, and sometimes endoscopic tests, endoscopy to be done for ruling out certain esophageal disorders and for tube and windpipe abnormalities. We can have home remedies for hiccups, like drinking upside down, that is, fill a glass with cold water, bend down at the waist and put your head down, slowly drink the water from the opposite side of the glass than you would normally do. Or you can breathe into a paper bag, tightly press a small paper bag around your mouth, breathe slowly and deeply into it. Repeat this several times while keeping the brown paper bag in place. Or you can just swallow a spoon of salt or sugar in your mouth, hold it in your mouth for 5 seconds and allow it to dissolve. These are some of the home remedies that can be tried for managing hiccups. If this is not helpful, then we can think of certain drugs also. But before moving on to drugs, we should always approach in a non-pharmacological way. That is, non-pharmacological therapy has the first place. Many of the traditional non-pharmacological remedies used in the ED have a sound physiological basis, as they have an effect on components of the hiccup reflex. The stimulation of the nasopharynx by applying forcible traction or to the tongue, or swallowing granulated sugar, gargling with water, sipping ice water, drinking from the far side of glass, biting on a lemon, or inhaling noxious agents can be helpful sometimes in managing most of the hiccups. C3 to 5 dermatome stimulation by tapping or rubbing the back of the neck, coolant sprays or acupuncture are also quite helpful. Diaphragm stimulation, diaphragm stimulation, removal of gastric contents, iced gastric lavage, Valsalva maneuver, cavity sinus massage, or sometimes like digital ocular globe pressure, digital rectal massage, breath holding, hyperventilation, gasping, breathing into a paper bag, pulling the knees, using continuous PAP, and rebreathing 5% CO2 or mental distraction sometimes works, and it is most often helpful in managing hiccups. Behavior conditioning, hypnosis, acupuncture too can be tried in cases of hiccups. Coming to the pharmacological therapy, most of the systematic reviews or literature says that treatment of the underlying condition was the most successful, but there were no high quality data to allow pharmacological treatment recommendations. But still, if we need to go for pharmacological treatment, then our approach should be in this form. If there is no remedy, no response to non-pharmacological treatment, then we should consider treatment with PPI first line. And then we should go for empirical therapy like first line baclofen, gabapentin, which is the preferred. And second line like metoclopramide, or third line like chlorpromazine. If it is still unresponsive, then we can have alternative management, like in cases of surgery, like that is intractable cases can be considered for phrenic nerve block. If we look at the drugs, then this is the pantoprazole, which has 40 milligram 1 to 2 times per day, and treatment of choice for GERD and empirical treatment while we are still awaiting evaluation. Next, we can have baclofen, 10 milligram TDS, first choice if neurological origin is suspected. Metoclopramide, first choice if peripheral origin is suspected. Domperidone, same, that is metoclopramide and domperidone have almost same indications. You can also use haloperidol, gabapentin, pregabalin, that is first choice for central origin hiccups. If less invasive treatments are not effective, then we need to have interventional treatments like stimulation of the vagus nerve and phrenic nerve block. Another option is to surgically implant a battery-operated device to deliver mild electrical stimulation to your vagus nerve. This procedure is most commonly used to treat epilepsy, but it has also helped in controlling persistent hiccups. However, on the basis of the limited data, the investigations still are lacking for the pharmacological treatment, but in some cases, we can also consider baclofen and gabapentin as first-line drugs. Chlorpromazine is the most thoroughly studied medication. To prevent or minimize hypotension caused by this agent, preloading the patient with 500 to 1000 ml of IV fluid is advised. Another major tranquilizer like haloperidol is effective in doses of 2 to 5 milligram. Several anticonvulsant agents have been also used to treat, like phenytoin, valproic acid, and carbamazepine have all been effective when used in typical anticonvulsant doses. Others can be sedatives, analgesics, anesthesia, like anesthetic drugs like ketamine, stimulants, and miscellaneous agents like hydrophonium, or sometimes benzodiazepines also, which can cause hiccups to be avoided. This is a rare case report long back where hiccup was controlled after swallowing a viscous 2% lidocaine solution for treatment of mucositis. Based on this experience, many patients have been treated. This is in nutshell the non-pharmacological treatment part, where we can see hypnosis, acupuncture, nerve block, or sometimes vagal stimulation, respiratory maneuvers, nasopharyngeal stimulation have taken place. Before moving to pharmacological treatment, we should always consider this treatment. Then only we should follow pharmacological treatment. Pharmacological treatment, we have already dealt with drugs like baclofen, gabapentin, metoclopramide, domperidone, chlorpromazine, carbamazepine, valproate, certain drugs like amitriptyline also sometimes quite helpful. We should be aware of all these side effects when we are providing such drugs. That's all. Thank you.
Thank you, Dr. Abhinav, for elucidating the causes and the etiologies and the pathophysiology, and Dr. Gunjan for taking us through the various treatment options that we have. Now, just to make this more interactive and to just go through some of the common things that we encounter in our practice, I know both the talks have been quite exhaustive. So, to start with, I would like to ask Dr. Abhinav Gupta. We're discussing chronic cough, but we do sometimes have patients who have short acute bouts of, not chronic cough, hiccups. We have acute hiccups as well. So what are the differences in the etiology of acute versus chronic hiccups? Because obviously our plan of management and approach will change accordingly.
Thank you, ma'am, for the introduction. And thank you again. Basically, the difference between acute and chronic is basically on the duration of the persistence of the hiccups. If it's less than 48 hours, then we can consider it's acute, and it's usually harmless. They can be either because of eating too much or eating heavily or drinking carbonated beverages in a large amount or consuming alcohol. Most common things are there, and which responds and which subsides spontaneously within a small period of time. In the chronic hiccups, if it persists for more than 48 hours, and they are usually due to the diseases, either because of the nerve damage, it can be there, as Saras told, or it might be because of the central nervous system disorders, like likely little medullary syndrome, stroke, or any meningitis, something, all those things, or any metabolic disorders, or any GI conditions like patient is having reflux, esophagitis, and pancreatitis, gallbladder diseases like that, or in malignancies. In those cases, then we have to evaluate accordingly what it could be done.
Sure. So I think, as you have said, most common causes of acute cough are transient, and they are usually GI related to some form of food or fluid intake and they are short-lived and then can be easily controlled. And which is why we are not talking in much in detail about it. Of course, chronic hiccups, you have given us exhaustive list of causes. And it's interesting because you can see that there are causes varying from respiratory causes, central causes, GI causes, malignancy, metabolic syndromes, various metabolic parameters, and of course, malignancy. So obviously, your etiology and your approach will be based on what are you suspecting based on the history that you're getting from the patient, right?
Yes, ma'am.
Coming to Dr. Gunjan, so you have given us a very detailed description of what are the various treatment options that we have available. So are there similar, are all these options to be used in a patient who has an acute episode, or we just use some specific measures? I'm assuming we don't use the pharmacotherapy, as you've already elucidated that even in chronic hiccups, we should not be using pharmacotherapy. We should be going for the non-pharmacological therapy first. So for what would be the measures that you would take for patients who have acute episodes and who are not technically falling into the chronic hiccup spectrum?
As discussed in my lecture part, I've already clearly mentioned that in any case of hiccup, whether it is acute or chronic, our first identification should be identify the precipitating cause. If you are able to find the cause, then try to remove that cause. If not, then only move to non-pharmacological treatment. Non-pharmacological treatment like drinking sip of water quickly with a glass, taking a lemon bite, or eating a sugar or salt a spoonful like this. Most of the acute hiccups usually go by these methods. We don't need drugs in that cases. We need drugs or pharmacological treatment only if our previous treatments fail. And if it is classified as persistent or intractable, then only we should consider drugs. But anyway, drugs are also quite useful in cases of hiccup that are not going on its own, whether it is acute or chronic or persistent. So treatment part is almost the same. Identify the cause, non-pharmacological measures, and then the pharmacological treatment.
Okay, great. So, Dr. Pravin, just to give you a case scenario. So you have a patient who's coming to you, a 60-year-old diabetic hypertension, past CVA, cerebrovascular accident, recovered completely, has also given history of tuberculosis effusion, which has been treated, but he still has some residual loculated collection. And he now presents with hiccups as his only presenting symptom. So what do you think could be happening to him? I mean, could it be a pulmonary etiology that is worsened? What would you look at? Because he has multiple comorbidities and multiple things which we have seen any of these could be causing the hiccup.
Yeah. So firstly, I'll thank CCI for giving me the opportunity. And coming to the question, so if this guy is 60, diabetic, had previous TB, had previous CVA, cerebrovascular accident, and now presented with the hiccups, and he had residual collection of loculated collection. So this could be again loculated empyema or reactivation of tuberculosis. There are there are few cases of pulmonary infection. They can present initially as a hiccup, and most of these case reports have come in during COVID time, because everybody was presenting case reports during that time. So there are few case reports with empyema associated hiccups have also been reported, and mostly this pathophysiology will be like there will be irritation of parietal branches of phrenic nerve, which runs over the superior surface of diaphragm. And if these loculations are along with the mediastinal pleura, that can present as a hiccup. So again, and this could be a even central vascular episode also. So with that, we'll have to evaluate for both the things. And if TB is the etiology, is like TB can also cause hiccups, though it is rare. So like TB meningitis, if it can affect any part of or any step of you can say what you call a reflex arc. So if it is affecting central part, could be a tuberculoma in the medulla oblongata, which is hiccup center, or could be TB meningitis. So even miliary TB can present as a hiccup. So and mediastinal lymph node tuberculosis that we should keep in our mind, like enlarged or infected lymph nodes can present as hiccups. So here, I think most likely cause would be a reactivation of underlying tuberculosis, and patient is having loculated empyema which is causing hiccups. So managing that loculated empyema is important to cure the hiccup episode here.
Great. I think as everybody, lovely analysis, Pravin, and you're absolutely right. This patient actually has a secondary empyema, but which is not TB, which is keeps getting a Klebsiella infection again and again because of the diabetes. And his only symptom that tells us that he's having an increased collection is his hiccups. And then when you do an X-ray, there is an increase in the loculated collection, and when you tap it, it is pus. So very beautifully elucidated, just to show that how it is so important for us to sometimes examine the patient. Like you mentioned tuberculous meningitis, you mentioned mediastinal lymph nodes. So it is important as to how when you examine the patient, which system it is leading towards, whether it's a respiratory cause, a GI cause, whether it's a CNS cause, or there are other metabolic parameters which are causing this. So it's important that we examine the patient, ask the right questions. So next question is for Dr. Ashutosh. So you have a patient who's presenting to you with chest pain and hiccups. What would be your thought process as a pulmonologist towards possible etiologies and further investigations? So, there is a patient who's just coming, otherwise no other comorbid history, no pre-morbid normal apparently, just chest pain and hiccups.
Good evening, ma'am. Good evening, CCI. Thank you, CCI, for promoting hiccup as a topic. So first of all, ma'am, we should search the underlying cause of the hiccup presenting with chest pain like simple pneumonia with pleuritis, pulmonary embolism, tuberculosis, mediastinitis, or simple carcinoma lung, underlying CLN, can present with the hiccups with chest pain. Some atherogenic causes also can present with chest pain and hiccup, like central line insertion itself can cause pneumothorax with chest pain, and insertion can cause hiccup. So we should search the underlying cause, taking proper history and investigation accordingly, like simple blood investigation, chest X-ray, clinical examination. We can do for the bronchoscopy, or we suspecting pulmonary embolism. We can go for the D-dimer or CT pulmonary angiography. We have to search the cause, underlying cause for the hiccup as well as chest pain. These are the common causes of causing chest pain as well as hiccups.
Yes, great elucidation. So respiratory causes, as you said, it could be either a pneumothorax, it could be effusion, it could be empyema, just a pneumonia with a pneumonic effusion, or thromboembolism.
Meningitis thromboembolism.
Yes.
Underlying cause CLN.
Yes, mediastinal lymphadenopathy, mediastinal tumors. Sometimes goiter also can cause, but there obviously you will see, neck enlargement. Over thoracic goiter. So it's interesting because there are actually some case reports where they have said that some patients have pulmonary thromboembolism have presented only with chest pain and hiccups. So just to remember that it should be one of the differentials, that if you are struggling to find a diagnosis, your X-ray is not showing any effusion or a pneumonia, then you should also think of it as one of your differentials. I'm not saying that you right away do a CTPA, but it should be in part of one of your differentials that you can, in your evaluation. So my next question, coming back to Pravin, in asthmatics, it is mentioned that asthmatics also can present with hiccups. So why do you think this could be a symptom in them especially? And would you treat the hiccup or the asthma in these patients?
As you said, asthma can rarely present with hiccups along with other symptoms like wheezing, chest tightness, or shortness of breath. But the pathophysiology is unclear, but there are some hypotheses where as all of us know, there is a smooth muscle contraction, there is bronchoconstriction and mucus production in bronchial asthma. So that is actually a vagal dysregulation because of parasympathetic activation, which in turn can stimulate bronchial branches of vagus nerve, which runs over the anterior surface of the root of the lung. So there is a bronchopulmonary plexus inside the thoracic cavity, which can get stimulated, and such patients can present as hiccups, maybe sometimes only the initial symptom, or along with other bronchial asthma symptoms like wheezing and chest tightness. So once the bronchospasm or once the acute exacerbation of bronchial asthma is optimized or is treated, then hiccups are getting settled. So we should treat underlying cause, which is bronchial asthma, and subsequently hiccup should settle down with the settling of bronchospasm.
Sure. And I think sometimes asthmatic patients also have GERD. And, I had one patient who used to classically have this paroxysmal vocal cord spasm. And then she would have this funny sound, which would sound like a stridor mixed with hiccups. And that would be her only presenting symptom. And actually, it would be an asthma exacerbation that is taking place. So it's interesting how different presentations can happen of the same disease.
Yeah, even there are some case reports where like OSA patients who are underlying asthma are presenting with hiccups. There are one or two case papers, and which are subsided with CPAP therapy.
Yes. So coming back to Dr. Abhinav Gupta, we also see hiccups in children. It's not just a problem with adults. And are there some different causes for hiccups in children compared to adults for chronic hiccups in children, and how do we approach the same? So obviously, we are looking at a lot of these causes that we've discussed are in adults, but children have their own special issues. Dr. Abhinav, are you there? I think he's not there yet. Anybody else would like to take that question? I don't know whether he's logged out or he can't hear us.
Yeah, so can I take this?
Yes, sure. Yes. Please, Pravin.
Yeah, so as adults, we see few pediatric population also coming to us when there are some pulmonary problems. So even children can present with hiccup along with all these mentioned underlying causes. So most commonly, transient hiccups are more common in children because they are fast eaters, and in infants when they suck the bottled milk, they have a lot of aerophagia, and that's why they get a transient hiccups and present with GERD symptoms also. And other most important cause I would like to mention is a nasal foreign bodies or airway foreign bodies. They can sometimes present with hiccups. So we should keep in mind whenever we don't get any other cause, we should look for the nasal or nasopharyngeal or airway foreign body with appropriate investigation.
Yeah, I think one of the other causes is also a foreign body in the external auditory canal, which sometimes, children have a habit of putting things in their ear, up their nose. So that can also sometimes, because of irritation, cause hiccups. And very often these patients come to the ENT specialist. Yes, sorry, we couldn't hear you in the middle, Dr. Abhinav Gupta. Would you like to add anything?
No, sorry, ma'am. There was a network issue along with it. I'm extremely sorry about it.
No issue. So anything that you would like to add, or can we proceed for causes?
Ma'am, the most common cause in children hiccups is basically because of gastric distension or reflux.
Yes.
These are the two main issues. Either it might be because of the improper feeding techniques to the babies, it might be because of that, or because of the aerophagia while talking or something like that. These are the two most common causes.
Yes. And I think in infants, when they are doing bottle feeding, they have not yet gotten used to how to do the bottle feeding. Sometimes, a lot of mothers will complain that, they'll while feeding, they'll start hiccuping and then they'll throw up. So that's one of the other causes. So moving on, Dr. Gunjan, we also have any particular reasons for hiccups in pregnancy? How do you treat these patients? And what are the likely causes? Because sometimes hiccups you have women who are anyways a bit uncomfortable, and then they come with intractable hiccups.
Hiccups in pregnancy are normal findings. There is nothing to worry for this. We are all aware that in pregnancy involves a lot of physiological changes. Now there are two lives, mother and the fetus. The fetus is growing and the organs are developing, and this causes us certain changes like shortness of breath. This is one of the factors that may trigger hiccups. There could be diaphragm maturement of the diaphragm irritation for this reason, for due to enlarged volume, thoracic volume, abdominal volume, and then we have hiccups. So there is nothing new. Lung mature of the baby, then fetal hiccups is also quite common because of the tickling or movement of the body or movement of the fetus in the abdomen. That also may be a precipitating cause for this. So we don't need to do, most of the hiccups usually go by first trimester. Sometimes morning sickness, nausea, vomiting, these are some of the tendencies of pregnancy that may provoke hiccup. So nothing new to be done. It is to be treated in the same way as we had dealt with. Usually giving a sipping and drinking of water, sipping water or salt or spoon, most of the things can go away on its own. Nothing to worry about it. No special treatments is required. Most of the hiccups usually go by second trimester.
Sure. Anything you would like to add, Dr. Pravin, as a pulmonologist, that if, sometimes these patients also come to us?
Yeah. So, like a lot of times, these like pregnant women, when they are near labor, they present with hyperventilation. So, because of that, there could be stimulation of hiccup reflex arc, and they can have hiccups. And one of the common cause in pregnant women are GERD, because they present with a lot of reflux, and which in turn can have hiccup.
Okay. So
some of the just
yes.
A moment, ma'am.
Yes.
Some of the things like that can be tried during pregnancy are some of the, like, keeping yourself calm, do some sort of meditation, some sort of yoga that is permissible for that in age group or that trimester. Then have a proper dietary meal.
Yes.
That is important. Avoid something beverages like sour pickle or something that is that may precipitate GERD. That things should be avoided. Better to go for alkaline things and some better dietary habits. Better sleeping patterns. That is also one of the things that is required to have a good sleeping pattern. These all things are home remedies, basically, that can be quite useful in dealing with pregnancy hiccups.
Yes. Sure. So, Dr. Ashutosh Gupta, any role of local medications for treatment of persistent hiccups?
Yes, ma'am. There are many trials. Case reports are there, as told by Dr. Gagan in previous in his slideshow. There is installation of local Jalocan viscous oral application of Jalocan viscous in the most probably CA patient, carcinomas patient can help. Sometimes lidocaine spray in the posterior pharynx, 10% can help. Sometimes Jalocan nebulization, 4% Jalocan nebulization can help. Even in intractable HIPL, one can try Jalocan injection, lidocaine injection, especially 1 milligram per kg stat, then 10 milligram IV Q 6 times a day can be tried depending on the situation. And sometimes ultrasound guided phrenic intervention can help with the Jalocan. We can do.
Okay.
There are certain case reports are there, but there is no clear-cut randomized trials for there. Different case reports are available only.
Sure. So, moving on, Pravin, what would be the cause of hiccups that you would see on your ICU rounds?
Yeah. So already Dr. Abhinav has elaborated the causes. So few of them are similar. Like if you see in pulmonary ICU, we often see ventilator associated pneumonias, pulmonary thromboembolisms, pulmonary infarctions, like previously mentioned, tuberculosis, empymas, and sometimes diaphragmatic tumors can present with hiccups. And in neurological patients, patients with Parkinson's, who have come with exacerbation of underlying Parkinson's, or stroke patients, whether it is ischemic or hemorrhagic stroke, or any central tumors, or cavernomas like astrocytomas, all tuberculomas can present with hiccups, and few metabolic causes, or you can say electrolyte imbalance like hypokalemia, hyponatremia, sometimes hypomagnesemia can present as hiccup. Hyperglycemia, diabetic, if sugars are high, that is one of the reason patients will have hiccups. Or like sometimes iatrogenic causes will be there, like central venous pressure line, or while intubating the patient, when you do pharyngeal intubation, that time also patient can have hiccup. So we'll have to give a proper sedation, or sometimes a muscle relaxant during the intubation. And a few abdominal causes like subdiaphragmatic abscess, which can irritate the diaphragmatic innervation of a phrenic nerve and can have hiccups. So these are the few causes of hiccups in ICU, what we see as an intensivist.
Sure. Dr. Gunjan, would you like to add anything to this? Or I think Pravin has given us an exhaustive set of lines. One thing I think that Ashutosh had mentioned earlier was central line insertion and pneumothorax. Sometimes it can be a heralder. Sometimes patients can just start hiccuping before we pick up the pneumothorax. So that is also one of the things that one can think of. Any other clues? Anybody else? So pulmonary embolism again, which if the patient is not presented with pulmonary embolism, sometimes just to go over the possible etiologies.
If you can identify the precipitating cause, then that is sufficient. That in itself is sufficient for treatment part of the hiccups. As we said, like if you have idiopathic reasons, or like placing IV line, or placing sometimes chest tube drainage that may precipitate hiccup, then we need to deal with that part only. In that case,
sometimes over RT feeding can.
Yeah, RT feeding. Sometimes even inserting a rice tube can NG tube can initiate hiccups. Then we just need to put out the patient, calm the patient, and assure the patient that nothing has been done, and it will get relieved. Just ask him to take drink a glass of water quickly, or put some salt or sugar in his mouth for 5 seconds and allow it to dissolve, and then allow him to drink a water. Sometimes rebreathing, that is very useful. Rebreathing in a paper bag and holding around the mouth and rebreathe, and that helps quite often. Then you can have this rectal this pressure, digital pressure over the eyes. That can be quite helpful in this treatment part of the hiccups. Then Valsalva maneuver can be tried. This is also very good technique for sometimes for relieving the hiccup.
But in ICU, generally we don't able to use this physical maneuver sometimes, most of the times.
Yeah.
So
in ICU, before giving this ocular pressure, we should always assure that there are no underlying condition that is not going to harm the pressure, because most of the cases that is recommended.
Yes. Okay. Anything to add, Dr. Abhinav?
Yes, ma'am.
This is an exhaustive discussion here, so if you want to add something.
As in my practice as being a gastroenterologist, I used to get many calls from different patients and different that we are having endoscopy, and after endoscopy I am having hiccups and they are not getting controlled. It's mostly because of the sedation that has been used during the procedure, and it usually occurs most commonly when there is an endoscopy is therapeutic procedure. In diagnostic procedure, usually a very short stancing, so abdominal distension is less. But in therapeutic procedures, it is most commonly seen. It's been seen because of abdominal distension, we are doing ERCPs, we are doing EMR, ESDs, we are doing APCs and all those things. So during that procedure, the abdominal distension is there. Post procedure, patient might have hiccups, which might persist for a duration of time, but usually transient less than 12 hours, not more than 12 hours.
Yes.
It's usually an iatrogenic, and it usually spontaneously subsides.
Sure. So it's just allaying the patient. I think that's the most important thing. Dr. N.H. Krishna has also posted over here. He said something about just asking a patient to keep taking deep breaths, deep inspiration and holding breath as long as you can, and repeating this again and again can also help in vanishing the hiccups in most cases. So
I would like to just add, ma'am, if I, yeah.
Yes.
Yeah. So, like I work in a large TB hospital. We do see a lot of a secondary pneumothoraxis where ICDs are inserted, and when ICD, like particularly when ICD is inserted on the right side, that could go till mediastinal pleura, and that can irritate the like branches of mediastinal, whatever parietal branches of phrenic nerve, and those patients can get hiccup. And few patients with alcoholic liver diseases, as we see alcoholic liver disease along with tuberculosis, they come with hiccups. Acute kidney failure patients also like can sometimes present with hiccups. So these are the few few cases what we have seen. We rarely see hiccup patients in OPD, as gastroenterologist must be seeing, but we tend to see such patients only in ICU or in wards, and those are also in few handful numbers.
Correct. And sometimes post-operative also we see, because post-op where there is probably some phrenic nerve irritation, because if there is a lesion that is next to the phrenic nerve, either intrathoracic or intra-abdominal, sometimes that can also cause post-operative, patients who are in the ICU. So
sometimes sedations also can cause hiccups.
Yes, the drugs also. Great. So similar reason why sometimes post-bronchoscopy patients come with hiccups. It is related to the sedatives that are used. So great. So moving on, Dr. Gagan, you have told us the long list of drugs, assuming that after all these non-pharmacological measures, the patient is still having hiccups. So which drug would you prefer? In which etiology? Do you have any preferences for which drug in the cause of the hiccups? And what precautions would you take while prescribing these drugs? If there is elderly patients or any other comorbidities, any specific things that we should, be careful of before prescribing?
Before moving towards the treatment part or approaching with the drugs, let's have I just showed in my presentation the algorithm. We need to take a beautiful history from the patient. We should try to elicit the underlying cause so that we can get a clue, because there are so many investigations, so many drugs to think about. But once we have a proper history, then we can definitely get some sort of clue as to what is causing these hiccups. Then we should proceed further. Go for the investigations if required, like ECG, X-ray, CT, MRI, or endoscopy later on, wherever you feel like. But once you are comfortable that now we need to start the drugs, non-pharmacological measures you have tried all those rebreathing techniques, holding slowly, rebreathing, asking the patient to deep breathe, take a deep breath and slowly in a paper bag, taking a sip of water. If all this doesn't work, then we should think of drugs. Now, once we have decided to start the drugs, then treatment of choice, if you consider the most common cause, then it is GERD. If you're thinking of GERD or any other benign causes, start with pantoprazole, or still pantoprazole is the drug of choice when as an empirical treatment while you're still awaiting the full evaluation of the patient. Now next line you can consider baclofen. Start with 10 milligram BD or TDS. First choice is neurological origin is suspected. Then you can go for metoclopramide or domperidone. That is also again a choice if peripheral origin is suspected. Domperidone has an advantage that it doesn't cross the blood-brain barrier, so it can be useful in such cases. Next in line, we can have haloperidol, 2 to 5 mg. You can think of all those things. Then you can have anticonvulsive drugs like gabapentin, pregabalin, and other such convulsive drugs like amitriptyline, all these things. If it's still unresponsive, then you have sedatives, anesthesia drugs like ketamine, other drugs to think of.
Okay. Any other comments by any other this thing? What about which drugs would you not prescribe in any particular patient? Anything that you would
chlorpromazine is still the standard drug that is being used in all elderly patients or in cases of drug of choice for anything that is not known to you. Chlorpromazine is quite safe and better drug, and you can use it anywhere.
Sure.
Only thing is that it is a hypotension. In cases of 25 to 50 milligram, if you're using, you then just give a load of fluid. That's all.
Okay. Anybody else wants to add anything to this? Dr. Gagan has very nicely explained the entire thing. Any other comments from any of the other panelists?
I can just add what we generally see in pulmonary wards. when patient is having underlying COPD or acute exacerbation of COPD and who are having already CO2 retention or hypercapnia. So such patients, we would like to avoid drugs with sedative effect like gabapentin or pregabalin, sometimes baclofen, we should avoid and give metoclopramide or other drugs which are safe. And in renal diseases, again, we should be careful when we use baclofen because they can have they can go into more like uremia or have delirium and have a secondary CNS side effects like they can become more dizzy or can have ataxia sometimes. So whenever you are using baclofen, use cautiously when patient is elderly and having underlying renal dysfunction.
So,
But in most,
yes.
But in most of the patients, baclofen respond very well with the hiccup.
Very well.
Yes.
Very well, respond very well.
In all those renal cases,
mostly
you can use
tolerated.
this chlorpromazine. That is also a good option to go for.
Yeah. But I think a lot of data is there on both these drugs, and in clinical practice, I think baclofen is easier.
Baclofen still stands in wards.
Chlorpromazine, yes. So that's what we'll end up prescribing if the patient is very uncomfortable till we come to a diagnosis of the etiology. And then, we have... so coming back to you, since you mentioned that obviously we need a detailed history, physical examination. Now we have gone through everything. Let's assume that the patient is not having any clinical signs to point us towards any disease. Like neurologically is okay. There is no signs of meningitis, no signs of increased CNS pressure. There is no signs of any stroke, impending stroke, or any of these signs. And no headache, nothing else whatsoever, even respiratory wise. So what investigations would you do? Like you have a patient, who otherwise has nothing else except hiccups. So what else would you try and do in the history? We have a question from in the chat box.
If you are unable to find out what any history or something like that, then non-pharmacological measures would be the best. First try them and then only think of any other thing. That is the only, if we are still unable to go. Then if I said in the last slide in my presentation also that while we are still evaluating the patients, we can try with pantoprazole, PPIs, or we can have certain like drugs like this xylocaine and other things. But movement to drug part is usually not advisable until we get some clue. Even in that cases we were discussing just right now, baclofen. If we are not able to find anything, then start with baclofen. Let's evaluate further to find out some cause. We have to find out some cause must be there for anything that is abnormal. If it is acute, then most of the cases will subside. And then we have this rebreathing technique, using the paper plastic bag around your mouth and then deep, slowly repeat it several times. Usually it helps us. Then pressing your eyes, taking ice water or pressing ice on your eyeballs. These techniques are also quite helpful in such cases.
Okay.
Usually home remedy measures and non-pharmacological measures, the hiccup goes off.
So we have a message from Dr. Hassan from Uttar Pradesh. He says that his father is suffering from hiccups for last 5 years. He's a known case of hypertension, diabetes, which is well controlled and investigated thoroughly, including a CT abdomen, but he's still having hiccups. So he wants our opinion on this. It's difficult to get into this without actually knowing the more detailed history. But I think the easiest thing would be to do is what Dr. Gagan has mentioned, is for lifestyle changes, some breathing maneuvers, maybe changing your diet, giving a course of PPIs is what one would do in such a case. Otherwise, obviously, this is not a question that can be answered in a chat on a webinar. It requires more detailed conversation and evaluation. So, moving on, Dr. Ashutosh and Dr. Pravin, both of you all can take this. So, what are the invasive treatments, that despite all of this, we've tried all drugs, we've tried the physical maneuvers, we've tried, apparently there is a patient who's not has any obvious cause for the one of the etiologies, and classical example of this gentleman's father. Any other invasive treatments that you would that you could, recommend a patient, assuming that everything else, we don't have a etiology specifically that is causing this refractory hiccup?
Yes, please go ahead.
Yeah, you can go ahead. Yeah.
There are certain intervention which can go for the refractory hiccups not responding with any pharmacological treatment. We can go for the vagus nerve stimulator, like sometimes diaphragmatic pacing can help. Sometimes simple ultrasound guided phrenic nerve block can help. If still this not done, you can go for surgical options. The surgical approach for the including phrenic nerve blocking by surgery. These are other measures which we can try in intractable hiccups not responding with any further treatment.
Okay. Yes, Pravin, anything else to add?
As sir mentioned, like when you don't get appropriate recovery with all these pharmacological or other non-pharmacological measures, there are few case series, few case reports where they have tried invasive therapies, like as sir mentioned, phrenic nerve blockade, either use UAG guidance or do surgically phrenic nerve radio frequency ablation, which is one of the cases. They have used vagus nerve stimulation using a battery operated device implantation. Then there is one case paper where they have used microvascular decompression of vagus nerve, and in one of the paper where patient had presented with pleural effusion, so they have done and even a drainage of pleural effusion didn't resolve the hiccups, so that's why they have done a thoracoscopic a clipping of phrenic nerve, and later on they again they did it under general anesthesia, and then they again reversed under local anesthesia, so that diaphragmatic function recovery happens back, like it can regain back. So these are few what you call invasive or surgical options you can try, but these procedures are only justified in extreme cases where you don't have anything, and all other possible conservative managements have exhausted before you should like you're going for this all this phrenic nerve disruption, because all these invasive procedures will come with a few side effects, sometimes you can unexpectedly block a brachial plexus, and if you are blocking phrenic nerve, which is very important now, they can present with a respiratory compromise or respiratory failure. So these are only justified for extreme and as a last resort, and shouldn't be tried as a first choice of the management.
Some people also tried on salt on use of positive pressure ventilation in intractable hiccups.
Yes, there was some case report where they have tried a short duration of positive.
Some Korean studies are there.
Korean study, yes. In 3 or 4 patients, they have tried it.
Yes.
I think basically it probably it stretched the diaphragm a bit with inflation of the lungs and relieve some of the diaphragmatic spasm. Yes. So one of the causes I was also reading interestingly was that, very often cancer patients come with hiccups. So it's not just related to the fact that they could have, disease process. It's also the treatment relation. So glucocorticoids, especially dexamethasone, is known to patients get dexamethasone post chemo, and that can be a cause of hiccup. And therefore, if they come with it frequently, one should pick that up and probably change it to methylprednisolone short course, which in a similar course like dexamethasone. So that's one of the things to remember, because these are some things that we sometimes always don't know. We miss it because this it's in great detail. Even when I was reading this, I realized there are so many potential causes of hiccups which one may not be aware of. So we have some comments from the Dr. Judip Chatterjee from Mumbai has asked, do antacids which have an anesthetic drug along with it work better for hiccups than a plain antacid like Gelusil? So we've already discussed that, yes, anesthetic would help, and some of these, which mucin gel and all, which have an anesthetic attached to it, do help, could potentially be more helpful than. I don't think there are large studies and all that are telling us what is the doses and all, but there could be potential benefit with that when you want to try an antacid. So, any comments on that, Dr. Abhinav?
No, ma'am. Local anesthetics always work well. They are the initial line of treatment. Initially, if the patient comes to any one of the physicians, the first line is always like that. We used to give PPI along with mucin gel, Algel, anything which have a local anesthetic effect in that, and then we see the response. If it doesn't respond, then we go on to step up with either baclofen or chlorpromazine, or if we are able to find the cause in between.
Sure. So Dr. Tridip also mentioned whether use of rebreathing or some nasal snares, which cause stimulation of the nasal passage with a small catheter, could that help in stopping hiccups? Any comments from any of the panelists?
Basically, maneuvers are designed to enter the normal respiratory function to cause hypercapnia, or stimulate or irritate the vagus nerves, or some irritation to diaphragm. So these any maneuvers can, if they cause the hypercapnia, stimulate, can break the cycle of the hiccup, can help. But never try it.
Any other comments from anybody? So rebreathing, yes, rebreathing mask, because CO2 rebreathing is known to, it can help in
hypercapnia. Can help.
Yes, hypercapnia can help, because hypocapnia in a hyperventilating patient is one of the causes of hiccups. So creating hypercapnia could help potentially with this thing. And as I think all of these basically go back to asking the patient to take deep breaths again. So coming back to your, what are the, in your practice, Dr. Abhinav, what are, like we've discussed, theoretical, a lot of theory. Let's come back to practical application. In your practice, what are the commonest GI causes other than, intake of certain substances, actual medical illnesses in the order of 1 to 5 that you could tell us that would probably take precedence as a presentation with hiccup?
And the most common cause of hiccup that comes into the practice in the practical scenario is the most common is reflux diseases.
Yes.
Either they might present with esophagitis or with globus sensations or all those things, or abdominal fullness. The first is this. Second is having a patient with postprandial distress syndrome. In those patients also. Third patients are those with having a chronic constipation that are also been shown to have because of abdominal bloating and abdominal distension, and with aerophagia, and they also try all those maneuvers of aerophagia to evacuate and all those things.
So IBD patients also can come with hiccups, no? Inflammatory.
Yes, IBD patients, yes, basically with Crohn's. IBD Crohn's may also present because of the involvement of the esophagus and the stomach, which is very rare. But in those patients also they can present with hiccups.
Okay. And pancreatitis patients, do they
also lead to abdominal distension, because pancreatitis eventually leads to an initially of abdominal distension, gastroparesis like picture in all those patients with diabetes, pancreatitis, hypothyroidism, all those things which leading to gastroparesis might eventually lead to development of hiccups.
Okay. So any chemotherapy drugs, Dr. Gagan, that you would want us to be aware of that would be causing hiccups?
Just
anything specific?
Just now we were discussing about some of the common etiologies. If we think of some of the common etiologies related to medicine ward, we have patients of a stroke where we find all these things. Then electrolyte disorders, that is one of the most of the common reasons. Then kidney dysfunction, like a high level of urea, creat. Then uremic NCAP patients, alcoholic hepatic NCAP patients. These all patients are prone to hiccups, and they present with hiccups most of the time, and we deal with it. Coming to cancer part, we have cancer drugs like chemotherapies. We see sometimes patients coming with chemo or taking some drugs like cisplatin, carboplatin. These patients are more common. with all this. Then certain patients with corticosteroids also, or benzodiazepines. These are some of the underlying drugs. That is, treatment part is to be evaluated. Like drug may be one of the cause of presenting hiccups. That needs to be dealt with, keeping in mind the background of certain diseases.
Sure. What about Dr. Pravin? In your practice, in your OPD, as we said that in order of etiologies, what would be the cause that would be? How often have you seen a patient with thromboembolism coming with hiccups? Meaning, like, is it a common finding or it's not very common?
Yeah, it is like sometimes they can present with chest pain and hiccups, but again, it is very rare presentation of pulmonary thromboembolism. Most commonly, they will present with chest pain, or sometimes hemoptysis, sometimes pleural effusion, having pleuritic chest pain or dyspnea. These are the like few things what we should keep in mind whenever patient is having chest pain. X-ray is absolutely normal. We should think of pulmonary embolism and do a proper evaluation, proper vascular evaluation with CT, pulmonary angiography if required. For other vasculature also, we should see if patient is having hemoptysis and hiccups, then a bronchial artery what you call angiogram we should do, and rule out the pulmonary embolism. And if having any aneurysm along with the pulmonary thromboembolism, like sometimes tuberculosis patients can have bronchial and pulmonary aneurysms, and they can present. There is one case report, like when we got this topic and we started reading it, so we came to know there is one case report of pulmonary aneurysm causing hiccup. So these are few cases what we see. Again, it is very rare presentation in pulmonary thromboembolism. And I would like to mention one example when where I have seen in my residency days in KEM hospital in Mumbai, where we have seen a girl, a young girl, adolescent girl who is having hiccups, and we have done all the evaluation. She has gone to all the OPDs, and finally it was psychogenic hiccups, and she was doing it for secondary gains, like I remember she was in 8th or 9th standard. So after ruling out all these etiologies, we should do a proper like a psychosocial analysis or evaluation, or a parent counseling, and find out the reason for hiccup if it is really psychogenic, and then we should like get psychiatric evaluation done.
Yes, so in younger patients, very often it is anxiety related or psychogenic. But interestingly, you mentioned female. Interestingly, literature says that hiccups is more common in men. I don't know the reason why, but while I was reading it, I thought it's interesting to mention that. So coming back to if you have a patient who is only having nocturnal hiccups, I mean, then what treatment would you give that patient? I mean, it's interesting, but just like, you have patients who have nocturnal predominance of cough. So again, it could be related to GRD, distension, abdominal distension, all those kind of things. But despite controlling that, so you would then want a drug that is a little sedative, right? Because then you want the patient to go to sleep so that he doesn't complain and doesn't have the perception of hiccups. Does that make any sense? Is there any data on that, Dr. Gagan, or any of the other panelists, please? This is such an interesting topic that we have a record-breaking 1,561 logins, but very few questions.
Great.
So maybe we could just have questions amongst ourselves and just, make it more interesting. So any thoughts on this? I just thought of
this nocturnal hiccup. As we are dealing with chronic hiccup, we self said in our first line that it is very rare in our clinical presentation. Acute is the most common, that is we often goes off. Chronic is rare to see. In that, again, this coming to a specific class, that is nocturnal hiccup. That is again a rare thing to notice about it. But still, if we have this kind of thing, then we can think of all those GERD. We can most often think of giving pantoprazole, or as we discussed, Xalocaine, Viscous, and other things. If it is still unresponsive, then coming to the sedative part, as you said, we can go for this centrally anti-convulsant drugs like pregabalin or gabapentin, something like that has a sedative effect that may be sometimes helpful to it. If not, baclofen still stands the first choice. Give baclofen, then you can see the result.
Yeah, often we prescribe baclofen. So often we prescribe baclofen, yes.
I think before giving sedatives, we should evaluate for the OSA.
OSA, obstructive sleep apnea, but
evaluate.
No, evaluating, we said that evaluation has not been carried out because if we come to the evaluation part, then we have to rule out all those heart failure things and heart conditions that may precipitate underlying condition, give him a 45-degree reclining position, all those things. If that doesn't win, that definitely we come to drugs only if other measures fail. In the drug part, we can try only these things that most of the drug part is usually based on trial basis. Because if we are unable to find any etiology or any cause, then we have to try the drugs. If non-pharmacological measures don't help us.
Yeah, we can try, like as madam said, we can give some sedatives if patient is really having some anxiety disorder or having problem with sleeping, then we should go ahead with benzodiazepines, lorazepams. If require, haloperidol also we can give in such patients in low dose, which is again a dopamine antagonist, so which is better tolerated than other dopamine antagonists like chlorpromazine, which is not a first line management now, but we can try all these medications like benzodiazepine, for example, lorazepam, alprazolam, or haloperidol if required.
Can I ask a question?
Yes, please do, because I'm running out of questions.
What is is there any role of psychiatrist or psychotherapist in this, in hiccups?
Yes. As I mentioned, whenever, like as madam has also mentioned, when patient is having anxiety, fear, stressful condition, or any like psychosocial problem, so we should get a psychiatric evaluation. And yes, definitely there is, if you are ruling out each and every organic cause and patient is having hiccups, and then we should definitely take psychiatric get a psychiatric evaluation done, and give psychoeducation or counseling to the parents or to the patient. And if nothing works, we have psychiatrists, all these beautiful drugs what I just mentioned, we can try this.
Role of psychotherapy, not any
one
drug.
of my slides
The role
I said
of psychotherapy.
Yeah, before we move on to drugs,
said that anxiety, stress, and these all are factors are responsible for creating causing hiccups. Now, if we look at the old age patients, there again this psychotherapy part comes. Pregnancy. These are some of the cases, commonly seen cases, clinical cases where we need to counsel the patient properly and take out the fear of them. And in old age patients, some of this chronic kidney disease patients, most often we see that uremia, and this one of the causes that they don't recognize. Uncontrolled diabetes. Again, it is a cause, it may be a cause for hiccup. So these things needs to be taken care of, and psychotherapy drugs are there. At last stage, if nothing works, then all these antipsychotic drugs are there in the list for treating hiccups. And psychotherapy part comes there, especially with the patient age group, that is pregnancy age group, old age group. They are more prone to psychotherapy treatments.
I had a patient, a middle-aged lady, whose children were all very busy and the husband used to be at work. So she would start hyperventilating and have hiccups, intractable hiccups, and then everybody would come, get worried about her. And then after a period of time, the hiccups would settle. This was a cycle that would keep happening again and again. So over a period of time, when we realized that what she needs actually is a little counseling, and the family also needs little counseling. So everybody needed some counseling for this to eventually settle down. So yeah, it's one of the commonest.
Pravin also gave example of that young girl psychotherapy. That was an ideal case for psychotherapy.
Yes.
You could have counseled that patient with a psychiatrist and things could have been better.
Yes. Okay. So coming back to you again, you've mentioned a whole list of physical maneuvers. Anything, that one maneuver that would help most?
That is rebreathing part. Placing a tight bag around your mouth then asking the patient to take a deep, to breathe deeply and slowly, and repeat this several times. This helps in building up this CO2 concentration and helps in eliminating of the hiccup part reflex. Hiccup reflex.
Okay.
This maneuver is quite helpful, and we have tried, and this is a very good result. Also, we have this with this.
So, if you had a patient who you could not get a cause, what all investigation would you do? You do a CT chest, CT abdomen, MRI, everything.
No, that's what I said. We need to find out a proper history, whether he's a diabetic, whether he's hypertension.
Assuming there is nothing.
Assuming there is nothing, then non-pharmacological measures take the upper hand. We have to try all those non-pharmacological measures. And usually, if there is nothing, it is acute. In most of the cases, it is acute, then only it is nothing. If there is a chronic cases or intractable cases, there are underlying causes.
Yes. You have missed that, which are probably something that has been missed and cannot be picked up.
That is keeping on the triggering the hiccup reflex, and that creates the arc.
Correct, correct. Okay. So, coming back to you, Dr. Abhinav, any particular thing that when you're prescribing PPIs, would you prescribe one over the other in these cases? As you said, you would prescribe something with probably a local anesthetic if you're prescribing a syrup, but in oral tablet forms, anything that is preferred one over the other? Not that I could come across any data on this.
Gagan sir is also saying the most important in prescribing drug comes first the history. If any of the patient is having any comorbidities, like this patient is having diabetic or chronic kidney disease or having a symptoms of gastroparesis, and those are presenting, I will prefer rather than prescribing for PPI, I will prescribe a prokinetic that might also resolve the symptoms. If the patient is having a symptoms of reflux and GERD symptoms like those, then I will prescribe PPI, and it's been advisable to prescribe in a double dosing pattern in the morning and in the evening to prevent the night breakthrough and to resolve the symptoms as soon as possible of any esophagitis or any gastritis is there.
Correct. So, Pravin, I mean, we've talked about asthmatic patients presenting with hiccup. Why probably do COPD patients not present? It's not mentioned as one of the presenting symptoms in COPD patients. Any thought process, Pravin and Ashutosh?
COPD patient may have some sort of hypercapnia and maybe they cannot present with hiccups.
Correct. And they usually don't have hyperventilation. Yes. They don't have, usually their diaphragms are already flattened. So, those things are probably something that they don't present with hiccups as much, because we know that it's usually the diaphragmatic and the intercostal spasm that causes the hiccups. So, I think we have exhausted all our discussion and our thought process. Let me just check if there are any further messages in the chat.
Meanwhile, can I take one?
Yes, please.
Can I ask one question?
Please, absolutely.
Gagan sir, you have taken all the thorough history, and you have ruled out all the organic causes, and patient is a young pregnant female, and now you are going to prescribe a drug, and patient is already on one of the PPI. Morning, evening, patient is already on gastric emptying drugs. So what is your next choice of drug in pregnant female?
If we have tried all these maneuvers, and if it is not working in a pregnant both, then we should keep the underlying both female and the pregnant baby in mind. And to be very frank, I have never come such a clinical case like this, getting with the drugs and other things.
Because all these drugs are when we were reading for hiccups, all these drugs,
then in that case we still have
pregabalin will have some effect.
Or,
even valproate will have some effect. Benzodiazepines will have some effect. So there is one case paper where they have tried nifedipine, a calcium channel
blocker. Yes.
Yeah. So calcium channel blocker, where they have used in first trimester of pregnancy. All other drugs are a class C drug, so we Like
most of the clinical cases that are with pregnancy are usually says that in the first trimester it may continue, but by second trimester it goes off. And if you are trying for PPIs, then go for others like Digicane and something like that, anesthetic part or the gel. That helps most. That has got not many side effects, and that can be helpful in that cases. So we can think of this analgesic drugs, something like that.
But that's a good point. If it still doesn't work, then that's interesting. That obviously then that will require a multidisciplinary discussion before we prescribe nifedipine to.
Nifedipine is not. There is no harm in prescribing nifedipine.
No, but we have
most
to
of
know.
The times we most of the times ऐसे भी हम लोग we prescribe most of the times due to blood pressure or something like that.
Yes.
Cancel channel blockers.
Correct. So I'm not saying that will be your first line.
And nifedipine is not contraindicated in calcium channel blockers most likely.
Yeah, we can give.
We can give them.
Correct. So that's. I think we will draw a close to our discussion today. We've had an exhaustive discussion on chronic hiccups. We also briefly discussed acute hiccups, and we've seen that any hiccup that lasts for more than 48 hours obviously requires an intervention. Usually hiccups are acute, are short lasting, usually mostly related to GI causes because of eating spicy food, eating too much, having alcohol, or having too much aerated drinks. And it usually settles with withdrawal of all this and with physical maneuvers, with deep breathing, or with taking antacid or GRD measures. But you also need to know that when you have patients who have a chronic hiccup, an intractable hiccup, it could be a signal to a large number of underlying medical conditions, varying from metabolic conditions like uremia, hepatic uremia, like renal diseases, like hyperglycemia, maybe like hypocapnia, patient who's hyperventilating, who's in metabolic acidosis and hyperventilating and having hypocapnia. Even patients who have neurological disorders, like what the lateral medullary syndrome is what Dr. Abhinav had mentioned. Then you have other meningitis, infections, respiratory causes like patients with asthma, patients with effusion, infections, pneumonia, sometimes with pleurisy, with pneumothorax, basically anything that is causing diaphragmatic irritation. And you have patients with loculated collections, empyema that we spoke about, one of our patients. Then there are cardiac causes like sometimes even myocardial infarction, pericarditis also, which can cause anything that is any disorder of the mediastinum lymph nodes, masses, goiters, any of these mediastinal lesions, abdominal distension, pancreatitis, what Dr. Abhinav mentioned, anything that causes abdominal distension can also lead to hiccups. And in children, we have very specific causes, mostly due to related to aerophagia and over distension of the stomach. So now we have a large overview of what are the different causes in these patients. We've also seen that OSA could be a cause for hiccups, and therefore we need to evaluate a patient thoroughly with a complete history and a general examination before we move to detailed investigations. And then, of course, the first line therapy is going to be physical maneuvers, changing the diet, maybe trying PPIs, changing your dietary patterns, decreasing your intake at a particular time rather than over distending the stomach. Especially when we have pregnant women, we can advise these things to them. And avoiding GRD, avoiding retching, if there is reflux, avoiding all those measures. And then, of course, you have physical maneuvers like deep breathing. You have other maneuvers like, stimulating the tongue, pulling the tongue, or eating something sour, or pressing the diaphragm. All these things have been described. And then, of course, lastly, we've talked about psychotherapy in patients who are it's psychogenic hiccups. And then, of course, coming to drug therapy. So drug therapy is a last resort. We all discussed how, we all have been guilty of prescribing baclofen easily because it's an easily prescribable drug rather than prescribing other drugs. And sometimes gabapentin to be avoided in some elderly patients or COPD patients who could be at risk of having increased hypercapnia, or having, sometimes patients also have excessive drowsiness because of these drugs. So one has to look at it very carefully. So with that, I'd like to thank all the panelists Dr. Abhinav Gupta, Dr. Gagan Gunjan, Dr. Pravin Taware, and Dr. Ashutosh Gupta for taking up this very interesting topic. And last but not the least, I would like to thank CCI for continuously for the last many years. I think it's been 3 years now that we are continuously bringing up new topics. I'm sure hiccups is not a topic that has been discussed by any other forum, and which is why we have so many logins. And I think everybody's spellbound. They don't have any questions to ask us also. Otherwise, normally there is a whole flurry of questions that comes into when you have these webinars. And it's must thank CCI for this initiative, which is continued without a break at all. Thank you and good night, everybody. Special thanks to Cipla also for being continuously being the academic partner for this continuum of webinar series. Dr. N.H. Krishna, Dr. Vijay Kumar, and everybody else behind the scenes who work continuously, Atri, Dr. Shivani, and Dr. Kirat, and everybody else who's there in CCI Executive Committee who's working endlessly for these webinars. Thank you, everybody, and good night.
Thank you, everyone.
Thank you. Thank you, ma'am. Thank you, CCI.
Bye-bye.